Hello, my name is Wendy Lomers, and we at Acclaim would like to thank you for taking the time to review this presentation. We hope that you will leave with a better understanding of the 2018 MIPS requirements and the changes as they relate to radiology. By now, you're aware of the quality payment program that Medicare implemented last year and the quality metrics that will be affecting the payments you receive for taking care of the Medicare population. While we have not felt this yet, we anticipate that these quality metrics will also affect the payments that you receive from other payers in the future. This presentation will focus on how MIPS will apply to the specialty of radiology. We will review the 2018 reporting requirements and show you where you can find the changes that were made to the 2017 metrics used in the past. As you know, Acclaim is here to help you with all things radiology. What you will learn is that almost all of the MIPS requirements can only be accomplished through the efforts of the physician or the group. Acclaim hopes this presentation will help you, our physicians, understand the 2018 MIPS requirements, and we will continue to guide you to the right resources as you face the challenge of the quality payment program known as QPP. Here is a list of the areas we will cover. We will review the major changes from the 2017 program, the weighting of the categories, the ways in which you can report along with the requirements for each component. We will discuss the potential payment adjustments that will affect practices in 2020 based on their 2018 performance. There are special statuses that affect the reporting requirements, and these impact most radiologists. In the end, we will look at some of the specific changes to those quality measures that are relevant to radiology and interventional radiology. I will also leave you with a set of resources you can refer back to. By now you're aware that there are two pathways. MIPS, which for the 2018 performance period will include a very large percentage of the physicians, and the Advanced Alternative Payment Models called AAPMs, which is the path that will be taken by those physicians who participate in a risk-sharing payment system. An alternative payment model, APM, is any model that is not strictly fee-for-service. It often includes incentives to the physicians for savings. An advanced alternative payment model is called an AAPM, and it requires that the physicians involved be subjected to downside risk if the cost of caring for the patients increases. This means that they would forfeit some of their payments or share in these increased costs. Participation in an AAPM with downside risk brings physicians together in a sort of collaboration, and it includes its own set of quality measures, so the physicians involved no longer report MIPS independent of the AAPM entity or the collaboration of physicians. All other physicians not involved in an AAPM must report MIPS to avoid the penalties of non-participation. For 2018, most of the AAPM participants work in integrated healthcare systems, but other AAPMs are being developed, and through research efforts, more of these types of payment models will continue to be added in the future. If your group is approached to participate in any type of clinically integrated delivery network of physicians, then you could potentially become involved in an AAPM, which may or may not affect your MIPS reporting requirements. Many of these are starting as part of a Medicare Shared Savings Program. If you are anticipating involvement in one of these APMs, please contact us so we can understand how it might affect your MIPS reporting requirements. 2018 MIPS still consists of 4 components, which are scored and result in a physician receiving a score between 0 and 100 points. Each component is weighted to accomplish 100%. Points and percentages are not the same. We will review the 2018 requirements of each category in more detail, but let's look at the changes first. You will note that quality is now weighted at 50% instead of the 60% weighting for 2017. This change allowed for the increased 10% weighting of the cost component for 2018. Quality also has included scoring for improvement over the prior year. Extra points will be earned if the reported data shows statistically significant improvement in specific measures. Cost is now weighted at 10%, and it is limited to 2 cost metrics. Even though there was no weight attributed to the cost component for 2017, the CMS still calculated the metrics and have included scoring for improvement year over year. This requires that the same cost measures are relevant for 2 consecutive years. The low volume threshold was increased to eliminate more physicians from the reporting burden. Another effort to reduce the burden is the creation of virtual groups. As you know, the physician can elect to report individually, or they can elect the group reporting option, which allows the entire group to report and share the same scores. This new virtual group option allows smaller practices with 10 or fewer physicians to elect to join together and report as a virtual group. They would then report and meet the requirements in the same manner as those practices reporting under the group reporting options, with the same special statuses available to them as are available to the group reporting options. The one caveat is that the election to be a part of a virtual group must be made with CMS prior to the end of the performance period. The 2018 performance period will end December 31, 2018, so the election to report as part of a virtual group must be made prior to that date. I have observed that Medicare's goal is to drive physicians into integrated delivery systems, and I can see the use of virtual groups as a driver toward that end. Once smaller independent groups begin to work together toward achieving their quality metric goals, they are more likely to continue to work together. 2017 was a transitional year and had lower reporting requirements. 2018 continues to be a transitional year, but the reporting requirements have increased. The quality and cost components must be reported for the full 12-month performance period. The data completeness requirement determines what percentage of your eligible exams for each quality measure must be reported in order to be eligible for full scoring on that measure. This changed from 50% of all eligible payer exams in 2017 to 60% of all eligible payer exams in 2018. There are some minimal points available for reporting measures that do not meet the data completeness requirement, but it will not allow for the highest potential scoring. Here's one of the areas where failure to meet data completeness requirement of 60% will still allow some points. Small practices with 15 or fewer physicians can obtain a minimum of 3 points for any measure reported, regardless of the performance percentage, and even if they do not report 60% of the eligible exams for that measure. This is a concession to help small practices with the burden of reporting. Physicians who work in small practices also automatically receive a bonus of 5 points for reporting at all. Physicians in practices that are designated as small, rural, or operate in HIPSA shortage areas, along with physicians who are non-patient facing, can report half of the required improvement activities to obtain full credit for this component in 2018. We will discuss how to find your specific designations in a bit because many radiologists are considered non-patient facing and hospital-based, and these physicians are exempt from reporting under the Advancing Care Information category, which relates to the use of electronic health reporting systems. For 2018, those who are required to report under the Advancing Care Information will continue to be able to use either the 2014 or 2015 Certified Electronic Health Record technologies. Again, most radiologists will not report under ACI. This is the weighting that has been assigned for the 2018 performance period. As you can see, the quality metrics have the heaviest weighting, and the resource use or cost category have the least weight. Until now, most radiologists have not been assigned most of the various cost components. The ACR and others in the radiology community are working to establish radiology-relevant cost measures for the future. There is no change in the rules regarding reporting as an individual or as a group. No prior election is required. You can make the decision at the time that you submit the performance period data. Once you decide, your election is across all components of MIPS. All components will be reported the same, either as an individual or as a group for that year. Even though some of the physicians in a group may fall below the low volume thresholds, these thresholds will be measured at the group level when reporting as a group. Once the group election has been made, even those physicians who may be below the low volume threshold will have their data included in the group's reported data. Under group reporting, all physicians within that 10 will share the same MIPS scores across all components. We will start with the quality performance category, since it is a category that most radiologists are familiar with. The 2018 quality measures align with the 2017 measures that the radiologists have been reporting, with a few changes. We will review slides showing the changes in a minute and discuss the best place to find this information. The quality component reporting requirement remains at 6 measures for 2018, and one of the 6 must be an outcomes measure, if there is an outcomes measure available to the physician or group. Each quality measure is identified with a measure type, which identifies whether it is related to improving a process, efficiency, or improving outcomes, for example. Outcomes measures are given more emphasis, and again, an outcomes measure must be included if you have one that you can report. Some measures are also identified as high priority measures, which means CMS considers them more important. And if an outcomes measure is not available to you, you must report a high priority measure in its place. Once you have met the 6 required measures, bonus points are available for reporting extra high priority measures. This can add up to 10% of the denominator to your score for this performance category. There is also a population measure that is calculated by Medicare using claims data. It requires no reporting other than filing the normal claims. CMS simply makes that calculation and applies it to that measure. In some cases, the physician or group can select to report on a specialty measure set, which, if successfully reported, would meet the 6 quality requirement, even if the set includes less than 6. I will show you the radiology-specific measure sets available for diagnostic and interventional radiology next. Specialty measure sets were developed to assist certain specialties in meeting the MIPS reporting requirements for quality. This one is related to diagnostic radiology. Here is the measure specialty set for interventional radiology. Now let's look at how the quality measures are scored and how the performance percentages are turned into a point score. Each measure is scored separately and the performance is divided into deciles. CMS calculates the decile breaks based on baseline national performance, which reflects the results of the 2 prior year performance periods, unless it is the first time a measure is reported and then it's based on the current year. Benchmarks are set separately for each type of submission. Claims is set separately from registry, which is separate from QCDR benchmarks. Performance is compared to published decile breaks. You can see where the performance percentages fall into each decile below the possible points. Points are assigned based on decile range, within which the performance percentage is located. Partial points are awarded based on where the performance percentage falls within the decile. Performance isolated to the top decile will receive a maximum of 10 points. Failure to report enough measures will result in 0 points for every measure that could have been reported. So let's look at this example showing the actual distribution of the combined performance percentages at the bottom. This shows how all participants' performance percentages fell within the deciles. As you can see, the top decile had a performance percentage between 86 and 100%. Anyone with performance at or above 86% will receive 10 points for this measure. That is because anyone in the top decile will receive the maximum of 10 points. A participant with a performance of 19% will receive about 3.3 points. It is important to realize that the highest performance percentages won't always result in the highest point score. Points are awarded based on how your performance compares to how others performed for that measure. If everyone is doing well, then your high percentage may score fewer points. Conversely, if everyone is doing poorly, and you do slightly better than they do, this could result in more points being awarded for a lower performance percentage. These are not valid scores, but they serve to make the point. In this illustration, the physician successfully reported the fluoro data required to meet the measure 75% of the time. The benchmark shows that this was only successfully reported by others 72% of the time. By outperforming the benchmark, the physician earned a score of 8 points. On the stenosis measure, the physician successfully documented it 92% of the time, but the benchmark set by past performance of a peer group was successful 96% of the time, resulting in the physician earning only 7 points. Note that the higher percentage performance did not necessarily result in the highest point score. The points earned are dependent on how the physician's performance compares to the benchmark. In the case of the mammography follow-up measure, most of those reporting on this measure are reporting that they use this system 100% of the time. Let's look at how 100% performance can result in 8.5 points. When the benchmark results in half of those reporting having a 100% performance score, the decile falls with half of the physicians clustered as you see here. When this happens, the point score is determined by the middle of the cluster. In this case, a 100% performance will result in a score of 8.5, not exactly what you would expect from a 100% score. That is why it is important to understand the benchmarks when selecting measures to report. CMS allows you to report on all the measures that you have available to you, and they will select for reporting those that result in the highest point score. CMS is implementing a portal on the web as part of the CMS Enterprise Portal, which is a website where CMS provides access to many programs. This site is expected to show the scores associated with the reporting data along with the benchmarks. Those that report through the ACR NearDear have seen the benchmarks presented along with each performance score. Understanding the relationship between the performance percentage and the scoring will help the physician maximize the physician's MIPS quality score, which in turn improves the MIPS composite score. Topped-out measures are measures that have been identified as easy to achieve. It is thought that there is little room left for improvement, so these have less value if the goal is to improve quality. This means that you may be able to meet the performance requirements 100% or a very high percentage of the time, but the measure will not produce the best point score. Once a measure has been identified as a topped-out measure, the score will be limited to a maximum of 7 points for 2 years, and the measure will be phased out over time. CMS will publish the topped-out measures identified each year, and it would serve to improve the scores of physicians and groups if they avoid reporting on these measures. Here's the list of the measures that have been identified as topped out for 2018. If you reported one or more of these in the past, you will want to select replacement measures for 2018 and avoid using these unless they are the only ones that you have available to you. For 2018, there are over 112 improvement activities listed in the final rule, and many appear to be relevant to radiology. The chosen activities must be performed over at least a 90-day period. Once completed, you must attest to the fact that you performed the activity and keep documentation in case you are audited later. CMS retains the current inventory of 92 improvement activities. However, they modified 27 of these activities and added an additional 10 new improvement activities, including the consultation of appropriate use criteria when ordering advanced diagnostic imaging. The appropriate use criteria improvement activity will allow MIPS-eligible ordering clinicians to earn a high-weighted improvement activity by attesting that they are using appropriate use criteria through a qualified clinical decision support mechanism for all advanced diagnostic imaging. The list of improvement activities with their relative weightings is available on the QPP website. Of relevance to radiology, several QCDR-based activities continue to be included as medium-weight activities, as well as the 7 medium-weighted activities that may be obtained by participation in the ACR's RScan project. If you are unfamiliar with RScan, you can contact the ACR to discuss the possibility of using this to meet your improvement activity requirements for 2018. It is important to mention that many radiologists will be designated as one of the special statuses shown here. If so, these radiologists can earn full credit for reporting half the required improvement activities. These physicians or groups must achieve 20 points for full credit under this component. Let's review the Resource Use Summary, another MIPS component. There is no special reporting for this component since Medicare uses the administrative claims data to evaluate spending in different areas. 2008 cost scoring will be based on 2 cost measures. The physician or group's cost data is compared to national benchmarks to determine whether they are above or below benchmarks. Being below benchmark on cost scores higher. The Quality Resource Use Reports, called QRURs, are produced each year, and they show the cost metrics attributed to each physician along with their other data. The QRURs for radiology groups have most often reflected only one cost metric, which is Medicare spending per beneficiary, and even its relevance to radiology is questionable. This metric accumulates all Medicare costs associated with an admission, starting 3 days prior to the inpatient admission and extending to 30 days after an admission. These costs are then attributed to the physician who provided the most physician services to the beneficiary. There is a lot more to this than I am stating, but that is the basic premise. For 2018, cost will be weighted at 10%, but the regulations require that this be increased to 30% soon. So even though there are not many cost metrics that are relevant to radiology, effort is being expended to identify more appropriate measures for future use because of this increased impact on the MIPS score. I have not been able to determine how the 10% will be handled if there are no costs attributed to a physician group. It is suspected that the 10% will be reweighted to quality. The Advancing Care Information component, dubbed ACI, attempts to score how well a physician or group uses electronic health record systems to improve or facilitate the quality of patient care. Most radiologists are designated the special status of hospital-based or non-patient-facing, or oftentimes both. Physicians with either of these designations are not required to report on the Advancing Care Information component, and the 25% is automatically reweighted to quality, bringing quality to 75% for these physicians. 2018 ACI reporting allows the use of 2014 and 2015 CEHRT, which is Certified Electronic Health Record Technology, or a combination of both, when trying to achieve the ACI score. If you are one of the radiologists who are required to report ACI, please let us know and we will get someone who can provide more resources to you as you try to accomplish this. This is a summary of the 4 components of MIPS that includes the point system, the weighting, and a brief description on how the scoring is applied. It makes a great reference tool. We are in year 2 of MIPS. The rules state that a composite performance score, which is known as a CPS, is that score between 0 and 100 points that is earned by a physician. If the CPS falls at or above the MIPS performance threshold, then there will be a payment incentive between 0 and 15%, depending upon the degree to which the CPS exceeds the MIPS threshold. If the CPS falls below the MIPS threshold, it will produce a payment decrease between 0 and 5%, again depending on the degree to which the CPS falls below the MIPS threshold. For 2018, there is an additional bonus that is applied to those with a CPS over 70. That would amount to $500 million per year shared amongst those with CPSs equal to or above 70. Note that the 15% maximum positive payment adjustment on the high side is only available if there are enough low performers who suffer the payment penalty. This redistribution of Medicare money is based on how well everyone performs as compared to the MIPS performance threshold, which is set at the mean performance for all. Here's the normal distribution and how the payment adjustments will be applied based on where the physician's or the group's performance falls as compared to the MIPS performance threshold. It also shows that the top 25th percentile will be eligible to share in the additional $500 million per year, and the lowest 25th percentile will receive the maximum negative payment adjustment. I indicate that this is the normal distribution. For 2018, you can see in the red writing on the left that the MIPS performance threshold has been arbitrarily set at 15 points, and the additional $500 million will be shared amongst those physicians who have a MIPS composite performance score of 70 or greater. This is a transitional concession for year 2. This one-year concession makes it unlikely that there will be many physicians receiving the potential maximum positive payment adjustment of 15% applied to their 2020 Medicare payments. Again, looking at the concessions for year 2 of MIPS, the minimum score needed to avoid a penalty is fixed at 15 points for 2018. Here are the examples of the efforts required to obtain 15 points and avoid the penalty. Each of these separately will earn at least 15 points. Since most radiologists are not reporting ACI, only the first 2 work for most radiologists. Meeting the quality component or reporting the required improvement activities will exceed the 15 points. It is our recommendation that the goal should be meeting as many of the metrics as possible to maximize the physician or group score. The payment adjustments grow over time, so now is the time to gain the experience necessary to be successful in each component. Again, let's look at how the 2018 Composite Performance Score will affect the payments for 2020. As mentioned, 2018 is the second year of MIPS, and CMS continues to provide concessions to help physicians gear up for this payment system. This shows the range of scores and the potential payment adjustments. Again, the regulations show a maximum positive adjustment of 5%, but that can be increased to as much as 15% if there are more physicians below the threshold who receive negative payment adjustments. I do not foresee reaching the 15% maximum because of the arbitrary 15% performance threshold. I've mentioned special statuses. I wanted to provide this chart which summarizes how the special status designations affect the 2018 reporting requirements. Since the ACI component requires the use of an electronic health record system, and hospital-based physicians do not control the electronic health record system that they use, they have been exempted from reporting ACI. Non-patient-facing physicians do not have the same opportunity to use the electronic health record since they do not interact with the patients face-to-face, limiting their ability to report on ACI. So they too have been exempted from ACI reporting. As you can see, the non-patient-facing physicians and those physicians and groups that are either small, operate in a rural or HIPSA shortage area, have the ability to obtain full CPI credit if they report half the required improvement activities. It is considered unusual for non-patient-facing physicians to have costs attributed to them. The concessions to small practices are made to lighten the burden of reporting for groups with 15 or fewer clinicians. They can earn 3 points for each quality measure reported, even if it does not meet the data completeness requirement of reporting 60%. And these small groups are also given an automatic 5% bonus. So how do you know if you or your group has been designated with one of these special statuses? CMS has specific definitions that apply to each special status, and there are determination periods that are prior to the performance period to allow the physicians and groups to know their status before the beginning of the performance period. This information is published on the web and available at the link shown here. Anyone can enter in the MPI of the physician, and it will show all of the practices that the physician is affiliated with. These designations are specific to the practice and can vary practice to practice, so care must be taken to identify the designation at the specific practice in question. Here on the lower left, you can see that this physician in this practice has been designated as non-patient-facing and rural. On the lower right, you can see that the entire practice has been designated the same. On the top, you can see that the clinician must be included in MIPS if they report individually, and must also be included in the group if this practice elects to report using the group reporting method. Sometimes a low-volume physician will not have to report if they report individually, but they will be required to be included when the report is done through the group as under the group reporting option. Each year, the CMS approves the quality measures that will be available for the performance period. The list may remain relatively stable, but it is not uncommon for the measure specifications to change. there is a document that identifies all of these changes in a list form called the Measure Specification Release Notes. Reviewing this list for any changes to the measures that you report will help make sure that you fully understand your reporting requirements. For example, it will make sure that you include all the exams, understand the requirements, and the exceptions. We will look at some of the changes to the radiology relevant quality measures. More details are available in the actual measure specifications, but this document helps you figure out what has changed. The document shows that Measure 145 had some CPT codes removed from the list of codes that require dose reporting or exposure time and number of images. I included the names of these codes, but the descriptions are not usually included in the document, just the CPTs are listed. You see here that Measure 195 shows that there was an updated note, which helps understand CMS's expectations on this measure. Again, the measure specification notes do not include the exact changes, but it does tell you that there is a change. Many people had asked the question about whether the use of a mammo tracking system had to be mentioned in the radiologist report. So this note was added to the measure specifications for 225 to clarify that question. Here, the changes for 265 were more numerous, and if you report Measure 265, you will want to look at the actual specification sheet to discover all of the changes. Obviously, some of the E&M codes were added. Again, this is Measure 265, and so just as an example, here's an excerpt from the actual measure specifications for Measure 265, showing the changes in red. Measure specifications can be found at this link, and most can be found by Googling the year and the measure specification number, such as 2018 MIPS Measure Specification 265. Each of these three measures are similar, and one change to the clinical recommendation statement was made on all three of these. That is the information called AUC indication that you show at the bottom. So there was an appropriate use criteria added in the clinical recommendation statement. Again, knowing that they changed helps you figure out which specifications you need to go look at. The notes show that one code was added to all of the optimizing patient exposure to radiation measures. For CT follow-up on incidental pulmonary nodules, they added the Fleischner Society recommendations. Here is the actual language that was added. I'm not expecting you to read this here. I just want to show you that the actual measure specifications now show the Fleischner Society recommendations. There are 5 recommendations. You can find a link to these on the resource slide. Here are some of the IR measures that have changes. Notice that 76 may pertain to all radiologists who place lines. For measure number 21, this was added to the clinical recommendation statement for the use of prophylactic antibiotics. Again, reading the specifications that change will keep you on track. On measure 76, here are the changes to the clinical recommendation statement about using sterile barriers. They simply added a few other society guidelines. If you report any of these measures, you will want to review the changes. Again, the link is on the resource slide at the end. Again, a few more changes. I just want to make sure that I show you all of the things that changed in radiology. There is also a link to a list of improvement activities that can be found on the resource slide. I mentioned again that RScan provides credit to 7 different improvement activities, and by participating in a QCDR such as the ACR Near-Dear, you do have access to some other specific improvement activities that aren't available to those who don't use a QCDR. And here's a list of references or resources so that you can go back and find this information that I've shown you. I am sure this all sounds very daunting. like learning a new language. Don't despair. Your efforts to become more familiar with these changes places you ahead of the game. The systems will continue to be developed, and the most important thing you can do is to gain a full understanding now and stay attuned to the changes. I hope that you feel your time was well spent. The changes in healthcare and their effects on radiology will continue, and hopefully we can journey through them together. Always feel free to call us here at Acclaim if you have any questions or concerns. We're here to help you.